Good afternoon, folks. Now, this afternoon's topic C, we're talking about end of life care planning for folks. Okay, so here we go. Here's a clear evidence-based summary of the scientific research on end of life care planning, grounded directly in the studies surfaced from your search results. This gives you a concise takeaway first, then a structured breakdown you can use for podcast segments, handouts, or caregiver education. Core takeaway: scientific studies show that advanced care planning ACP improves documentation for patient preferences and can reduce unwanted interventions, but outcomes vary depending on how ACP is delivered. A home-based palliative care consistently improves quality of life and reduces hospital use, while major inequities persist across racial, ethnic, and LGBTQ communities. What the research shows: advanced care planning works, but not equally for everyone. A large, pragmatic, cluster randomized clinical trial, 64,915 older adults tested a primary care ACP program called Sharing Choices. It found give me 1 second, folks. These papers are more documented end of life preferences in the electronic health record. EHR. Only 4.6 of patients engaged in facilitated ACP, showing how hard it is to scale. A subgroup of seriously ill patients actually received more potentially burdensome care, e.g., hospitalizations, near death. Okay, researchers emphasize measuring patient relevant outcomes, not just documentation. Interpretation: documentation improves, but ACP alone doesn't. Guarantee care aligns with values unless systems, families, and clinicians act on those preferences. 2. Home-based palliative care improves quality of life. A 10-year systematic review of home-based palliative care, or HPC, found significant improvements in quality of life, higher likelihood of dying at home, matching most patients' preferences, reduced hospital admissions, ED visits, and length of stay. No major differences in symptom control compared to usual care. Interpretation. Bringing palliative care into the home is one of the most effective ways to honor patient preferences and reduce unnecessary medicalization. Major inequities shape who gets good end of life planning. Research scan on disparities in end of life planning found lower rates of advanced directive and healthcare proxies among Black, Hispanic, Latino, Asian American, Native Hawaiian, Pacific Islander, Indigenous, and LGBTQ communities. Higher likelihood of in hospital intensive treatment at the end of life, inadequate planning or inadequate pain management, and limited access to hospice and palliative care. Experts recommend policy changes to expand culturally responsive ACP and reduce systematic barriers. Compassion and choice. Interpretation. ACP must be culturally tailored and, and equally focused to be effective. A broader evidence landscape. What matters most at end of life? A major evidence review. AHRQ-NIH highlights the outcomes that best reflect quality of life care, pain and symptom control, clear, empathetic communication, care aligned with patient preferences, support for family caregivers, and coordination across settings. Interpretation. Planning is not just paperwork, it's communication, coordination, and emotional support. What this means for families and clinicians. Across studies, the strongest themes are ACP is most effective when facilitated, not left to patients alone. Home based palliative care is a powerful tool for comfort, dignity, and preference aligned care. Equity gaps must be addressed to ensure ACP benefits everyone. Documentation is necessary, but not significant. Systems must honor The plan. Advanced care planning. ACP in primary care increased documented end of life preferences, but did not reduce and in a subgroup increased potentially burdensome care. Death. Uptake of facilitator led ACP was shrinkingly low, 4 to 4.6%. The study is one of the clearest illustrations of a paradox in modern end of life care. We can improve the paperwork without necessarily improving the experience of dying. It shows how ACP, when implemented at scale in primary care, can succeed at getting more preferences into the electronic health record. Yet it's still uh yet still fall short of shaping the care patients ultimately receive. Core findings. Quick guide. What happened? A large real world cluster randomized trial called Sharing Choices tested whether a structured ACP program embedded in primary care could meaningfully shift end of life care planning. Primary outcome. The intervention doubled the rate of new end of life prefer- preferences documentation, 12.0% versus 6.6% among patients without prior documentation. Engagement. Despite extensive outreach, only 4.6% of eligible older adults completed a facilitated ACP conversation. Unexpected results. Among seriously ill patients who later died, the the intervention group experienced more potentially burdensome care, such as hospitalizations or intensive treatments near the end of life. This combination of improved documentation but worsened care intensity is a critical signal for clinicians, health systems, and policymakers. Method snapshot design. A pragmatic cluster randomized clinical trial, meaning it was conducted under real world conditions rather than in a tightly controlled research environment, setting 51 primary care practices across two large health systems. Population 64,915 adults age 65 and older with scheduled primary care visits between March 2021 and April 2022. Intervention components: a personalized introductory letter encountering or encouraging ACP, access to trained ACP facilitators, a person family agenda checklist, a structured conversations, shared patient portal access to support family involvement. A mailed evidence advance directive, printed educational materials. This multi-component design reflects how ACP is increasingly delivered, not as a single conversation, but as a coordinated system of prompts, tools, and supports. Key members and evidence. Total sample 64,915 older adults. Intervention 22,949. Controlled 41,966. Documentation gains 12.0% of intervention patients had new EHR documented preferences, 6.6% in control group. Facilitator engagement. (1,181) patients completed a facilitated ACP conversation. This required 17,931 outreach attempts, highlighting the labor-intensive nature of ACP. Burdensome care. In a subgroup of seriously ill decedents, the intervention was associated with higher rates of potentially burdensome care, raising concerns about unintended consequences, interpretation, and practical implications. Documentation alone is insufficient. ACP is often measured by whether a form gets completed or a preference entered into the EHR. The study shows that documentation does not automatically translate into goal concordant care. Preferences must be visible, understood, and actionable at the moment decisions are made. Low engagement limits impact. Only 4.6% of patients engaged in facilitated ACP, despite multiple outreach attempts. This reflects real world barriers, limited time, emotional discomfort, completing priorities, and complexity of ACP materials. ACP can unintentionally increase aggressive care. The increase of burdensome care among seriously ill decedents is a warning sign. Possible explanations include documentation that was incompleted or misinterpreted, clinicians defaulting to aggressive care despite documented preferences, family or surrogates not being fully aligned with the documented plan, ACP conversations occurring too early or without adequate clinical context. This underscores the need for ACP to be integrated into clinical pathways, not treated as a standalone administrative task. Key considerations for clinicians, systems, and families. Measure what matters. Focus on patient-centered outcomes, symptom relief, comfort, and goal coordinated care, not just whether a form exists. Invest in facilitators. High quality ACP requires trained personnel who can guide conversations. Tailored outreach, culturally responsive, community specific. Approaches are essential for meaningful engagement. Making preferences actionable. Ensure EHR visibility, clinician awareness, and use of tools like POLST, MOLST that translate preferences into medical orders. Engage families early. Surrogates must understand and support the patient's wishes to prevent conflict or crisis-driven decisions. Limitations and risk. Generalizability conducted in only two healthcare or health systems. Results may differ in other regions or populations. All right, folks, I see you tonight for other shows. I'll do another one tonight when I get home. For now, Gator Wellness, take care, folks.